Welcome to this OrthoHub ODM. I'm with my colleague and good buddy Alex Vris, who's a trauma and limb reconstruction surgeon at the Royal London Hospital.
Hi guys.
And we are talking about complex tibial fractures. So, we're going to kick straight off. 38-year-old female, fit and healthy, motorcycle versus car. I could tell you, this is an out-and-out segmental tibial fracture. There is no distal
Nothing
extension.
in the joint.
There's nothing going up to the joint. It's like CT shows that that's all clear. So this is out-and-out segmental tibia. What's going through your mind when you see this sort of thing?
Nail it!
Really?
Really? You think you could nail this?
You're that good?
Nail it! I'd smash it.
But it's quite a proximal fracture, Kash. I'm thinking you might not be able to get hold of that proximal.
Nail and plate.
Nail and plate. Okay, just one
plate?
plate?
Just one plate. Maybe
Sure.
two.
Looks, he's done it before, right? He's done it before.
2 plates.
So,
Okay.
so yeah, that's what happens in the trauma meeting, right?
That is what happens in the
That's
trauma
what I
meeting.
like. You think
Yeah.
of the implant, you want to
You
use that.
think of a
name.
technical solution for that
Fine.
fracture.
Metal.
Metal.
So,
Okay.
let me tell you how I go about it. It's a young patient, fit and healthy, and we know from the story that a lot of energy has gone into that bone, right?
Yep.
And into that leg. And I'm thinking of doing the unthinkable
What?
and going to
What,
see
nailing
the
it?
patient.
See the patient?
See the patient.
I haven't done that since 2016.
Maybe with him together because I haven't done it since. So yeah, I want to go and see the patient.
You're going to see the patient.
And then her leg looks like that.
Okay, so we've got a bit more information now.
A bit more information.
Yeah.
So now you know.
So the patient is sensible. She's sensible. She's actually, you know, this wasn't her fault. She was motorcycling safely, and a car just came straight across her, completely wiped her out. So this is like an unfortunate situation. Shit happens. Now, what's going through your mind?
So you see that huge blister there. That tells me that again, a lot of energy is gone in that leg, and thankfully the skin is still intact. But I think she's lucky. It could have been open, right?
It could easily have been open.
Easily.
Yeah.
Now I'm looking at this segment of bone, and I thought most of the force of the impact has gone into that segment. Okay.
Yep.
I know, but most likely the nutrient artery is compromised. I'm not saying it's gone, but most likely it's thrombosed, gone. I cannot consider it to be
Reliably
intact. Okay.
Yep.
I know that those two fracture lines tell me that the endosteal blood supply is not
Endosteal
there.
blood supply gone. Yep.
And from the similar cases we've seen and we've opened and we've treated, we know that the periosteum most likely has been crushed, has been stripped of the surrounding tissues, some kind of internal degloving injury.
Yeah.
You know what I mean?
Yeah.
Okay.
If you were to unzip the skin completely top to bottom, that piece of bone would not be completely devitalized, would it? But it would be partially compromised.
It would be. It would be. Sometimes
Certainly-
you see
certainly
them. You know,
the
you put your finger and it just falls off.
Right.
If you want. Yeah.
That's it.
So
And the skin?
it's hanging. The bone is hanging from a thread. The skin now is holding on, but you can push it over the edge one way or another, right?
Yeah.
Let's say you leave it alone. Okay, I don't expect it to open. If it didn't open during the injury, it won't open now, right?
Yeah.
But if you go and make big incisions,
It won't heal.
it won't heal. That big blister might turn into an eschar, and
Yeah.
the skin might die. You might trigger a compartment syndrome that's ready to
Right,
happen,
okay.
right?
Yeah.
You might need to do fasciotomies. So it's an angry skin.
It's an angry situation.
Angry situation.
Yeah. Okay.
So
have you got a way of thinking about these injuries?
We have our internal way of thinking by working with plastics a lot. And let me show you. 2 big categories of fractures. Closed and open. Simple, right? The
Yep.
skin is intact, the fracture is closed. The skin is open, the fracture is open. A fracture, whether it's open or closed, it can also be low energy, with intact skin, with good patient characteristics, can be a simple fracture, an
Yeah.
easy fracture to treat.
Yeah.
So whether it's open or closed, whether it's a simple spiral tibia fracture that's closed or has a puncture wound, doesn't make a real difference, right?
Right.
You wash, you close it, and you treat it like a closed fracture.
Yeah.
But if it's like that girl here, high energy, lot of soft tissue injury, segmental complex fracture patterns, you know that this fracture is complex.
So actually, if you take those two injuries, a closed complex versus an open complex, which is the one to be most fearful of, would you say? I'm kind of preloading that question.
who are you most afraid of?
Who are you most afraid of?
Dr. Jekyll or Mr. Hyde? So
Well, Mr. Hyde's pretty scary when you meet him in the street, right?
that's the open
That's
complex,
the
right?
open
You
complex.
can
He's
see.
like, ah! Yeah.
It prepares you for what's going to
Right.
happen. You're calling plastics, you get a senior person in theatre.
Antibiotics, dressing, everyone is fired up. Like theatres know something's coming.
Exactly, get a frame ready. We might need a dermatome, we might need to do fasciotomies, we
Yeah.
might need to stage it. You tell the patient that.
Yeah.
Okay, the family, it's not a simple thing.
Yeah.
But when it's closed.
And also the patient has seen the bone sticking out of their leg,
Exactly,
most likely.
exactly.
They know this is bad. They're like, oh my God, they're going to have to chop off my leg.
Now imagine that you're the patient, you come with a closed complex fracture.
Yeah.
And you can see that it's swollen, but the skin is there.
Toes are moving.
Toes are moving.
I think you're going to be okay.
It's
I think this is going to be
and then
all
you
right.
wake up with like a ton of metal around your leg.
Yeah.
Open wounds, vac dressing, sucking air.
Yeah, multiple free flaps.
And they tell you that you're gonna need for us to take some tissue from there and put it there, and maybe you need a frame for bone transport. I said, what the fuck has happened?
Yeah.
So the closed complex fracture might get you unprepared.
Right.
Might mask under healthy skin.
Yeah.
And might not show its real identity
Yeah.
from the beginning. So that's why I think.
So
it's
Mr.
more-
Jekyll is actually the one to be afraid of.
Dr. Jekyll, yeah.
Dr. Jekyll is the one to be afraid of. Because as soon as he takes his clothes off, it's an absolute horror show. But until he does so, you don't realise that he's actually Mr. Hyde, hiding under an intact skin.
Exactly. So, what do you think happened?
What do I think happened? I think what happened, I think it got what Kash was suggesting. Got a nail. Oh!
2 blades!
That's not my X-ray. That's not mine.
Okay. That happened when Kash was on holiday. And
And we're also seeing on the right-hand side what came of it. And so obviously this went horribly wrong, and we wouldn't be presenting this case otherwise. But
let me tell you a real life scenario. What happened here? Okay. The intention was to do minimally invasive orthopedics.
yeah,
Okay, you get it. So you start by saying, okay, I'll do a suprapatellar nail with an incision away from the zone of injury,
Yeah.
right? And put my guide wire down and my reamer, reduce the fracture. Then I'm going to do a small MIPO incision here anterolaterally to hold
Yeah,
the reduction. Maybe make it a bit bigger to fit the plate, and maybe another one to lock the plate.
Yeah.
Same thing for the medial plate.
side
as well.
little cut here, little cut
Suddenly
here.
you have-
It's all minimally invasive. There's nothing going
Yeah,
on
but
here.
you have
It's
one,
almost
two.
like nothing happened.
Yeah, no one's been there. And then in the end of the case, compartments are super hard and it's tense, and then you do your fasciotomies.
So this is a monster surgery that's gone on, isn't it? So it's absolutely no surprise it ends up in a fasciotomy. So now you've got 2 plates and a nail.
Devitalized skin.
We were talking about endostic, like the nutrient artery earlier on, weren't we? That's obviously that's gone, right?
I think that's good. And most importantly, to put those 2 plates on and do your fasciotomies and everything, I'm sure that the periosteum around the bone
is
pretty
pretty
much
marginal
gone.
at this
It's pretty
point.
much gone.
Yeah.
So yeah,
So when this gets infected, there's really no resilience in the system because there's so
Nothing.
much dead bone going around.
so it's what I say to my trainees sometimes. Everything is a complication, from a pin site infection, from a DVT to this.
Yeah.
Right? But this is a bad complication. It might not happen every time. You might not get an infection every time you do a nail and a plate, right?
Yeah.
I'm not saying that this will happen 10 out of 10 times, but if it happens, that's a year and a half in a frame
Yeah.
to reconstruct that.
To reconstruct that,
infection, right?
yeah. And the patient will walk again, but boy, they've got a journey to go through before they get there.
So let me tell you what you could have done instead. So 2 ways I'll think about it. I'm a frame surgeon, but I'm not religious about frames. I try to avoid them. I like to have them as an option. You know, I
Yeah.
like to have them as my last resort. So if the patient is on board, cannot tolerate any complication, needs for any reason to be weight bearing from day 1, I'd frame it.
Right.
Okay, I'm not saying that this is the only solution.
Yeah.
The other option, which would apply to, I'd say, 90% of surgeons,
Yeah.
would be to wait. It's
Yeah.
safe to wait.
Yeah.
Because a closed complex fracture will not stay closed complex forever.
Yeah.
It will either become a closed, simpler fracture,
A closed, slightly less complex fracture.
or the skin will die and it will become an open fracture.
Yeah. Yeah.
So it will go one way or another.
Yeah.
It won't stay like that forever.
And by far the most common scenario is that it just backs off and sometimes you get an eschar forming, but usually the skin survives and the swelling goes down.
Exactly.
And your if this is compartment syndrome and the injury has brought you right up close to it, it kind of backs off that position over a few days. So go on then, let's say I've taken all your, I've walked off with all your framing
All
gear.
my friends, like nothing, no sense, and my CNS.
The budget's stripped. So you've only got plates and nails on the train. How long are you leaving this before you would happily put a nail down?
Between 1 and 2 weeks, I think is a good window.
Okay, but you give it a good 7 days, would you?
If in 3, it's not about the static image only, it's about the trend as well.
Yeah,
if you see that there's a massive improvement in the first 2-3 days, you can say, okay,
fine.
We're safe, we'll go ahead.
We're good to go.
We're
You
good
go
to
to 3
If
days.
it stays the same for 3-4 days, nothing changes, you're a bit more defensive.
You know this was the right. This was the right call. Yeah,
exactly. So
Okay, so just a bit of delay. Would you? Okay, there's going to be people watching thinking, what about an X fix? Why don't you just X fix this?
Yeah. It's not wrong. It's not wrong. It's a bit tricky. It's not a simple like standard.
It's not
standard
straight.
X-fix.
It's not straight X-fix, right?
No, because you have to find a way to put at least 2 pins in the proximal segment that is very small.
Yeah.
If you are planning to nail it, it's good to put them a bit posterior. Maybe use a denim and an oblique anteromedial to posterolateral.
Show
pin.
me.
So you might want to do a denim there. You know, if
this is the back.
If this is the fibula head here.
Yeah.
Just above it, a bit to the back where. Put a denim pin there.
Yep. So it's coming. So your entry point for a nail will be here, so that's well away from where you are.
Yeah. And maybe another
pin
there or there. Yeah.
Yeah. Like something coming in
like that.
Yeah.
Again, away from my nail.
Yeah.
This middle segment here, I would maybe put leave it for the end. I would put another pin in the distal tibia and maybe one in the calc as well to create a block distally.
Yes. Yeah. That you could combine together.
And maybe from those bars connecting those 2 segments,
just straight down the sides.
I might drop 1 pin in the middle segment if I think it's too unstable.
Yeah.
Even unicortical, just to hold it there and not
and stop it wobbling around. Yeah.
In the end of the case.
Yeah.
So ideally, you want the soft tissue to scar up in a favorable position.
In an
for
elongated
nailing.
position.
Exactly.
Yeah.
You don't want them to shrink.
Yeah.
Stay shrunk, and then when you try to nail it, you cannot reduce it. That's all you need. If I put an X-fix on, I wouldn't wait too long. Because you get pin site infections, you might get colonization. I'd try and do it within a week.
So actually, just sticking this in plaster would it actually have been the ideal thing, assuming the soft tissues aren't tented over. I haven't given you a lateral, so on the lateral it might be sitting like this. In which case,
it depends on the skin and the skills, and it's not wrong.
Yeah,
I agree that an X-fix in the Western world is a much more,
socially
acceptable solution. Yeah,
agreed.
So that's my case, and that's how I would treat this one.
Okay, so here's your next one. 72-year-old, frail, comorbidities, low energy. Is a low energy fall at home? What are your thoughts here?
Nail! On a plate!
On a plate! Nail on a plate. Okay.
You know what? You might be right this time.
Damn!
So, totally different beast, right?
Kash can't actually see the x-rays, by the way.
2 plates.
He's doing soft tissues for the last 6 months. He wants to put some metal in a bone.
Okay.
So totally different beast.
Yeah.
Low energy, soft tissues intact. I've gone and seen the patient.
Okay.
Done the unthinkable again, right?
Fine.
But this is a closed, simple fracture in terms of soft tissue injury.
Right, because it looks complex. You look at that, that's a complex tibia. But it's actually, they're simple fractures, aren't they?
It's simple, but it's 2 fractures. It's 2 totally different fractures.
Yep.
It's not a segmental fracture of the tibia.
Yep.
It's a lateral tibia plateau and a tibia shaft.
Yep.
That, you go back to the basics, AO teaching.
Yep.
What do you want to achieve? Forget about the implants, okay?
Right.
Even if Kash is right, forget about the implants. Okay, what do you want? You want the joint to be reconstructed, to be reduced, anatomically if possible.
Yeah.
Okay, you want a rigid fixation, absolute stability.
Absolute stability.
Buzzwords,
Yeah.
absolute stability for the condyle. And then you want to restore length, axis, rotation, and depending on the fracture pattern, absolute or relative stability for the shaft. Now, how I think about it. What implants can give you that?
Yeah.
What you need.
Yep.
You can say a frame can do it. You can put olive wires at the top and, okay, fine. But maybe it's overkill, right? Soft tissues are fine. There's no reason to use a frame. So what I do is treat it as 2 separate fractures.
So what would you do for the plateau?
I would do open reduction, plates and screws.
So
I
you're
would go and
okay, so you're running a plate up here and we're coming in here. Okay, and we're pushing that across. Yeah.
The first thing you might think is like, okay, I'd like to get this fragment up in the joint, but most importantly, for a 72-year-old, I want to bring this lateral condyle
Absolutely,
under the lateral femoral condyle, right?
In this sitting, the split is way more important than depression.
Because you don't want this condyle, when she weight bears, to fall into that, hole, right?
Exactly right.
And then when I achieve that, I think a plate and screws would be reasonable, but I'm open for discussion.
But you could just put two big cannulated screws there, couldn't you? Quite easily.
Easily. It's not wrong.
Yeah.
If the soft tissues allow you to, you can do whatever you want, but at least you achieve reduction and stability. And then I would run a nail down the shaft.
Yep.
Okay.
So what do they do? Let's see what they did. They did exactly that. It looks to me like they did the nail first, then the plate.
What would you do first?
So, for me, if you look at that lateral, this one here, what you can see is, I mean, you did this, right?
Yeah.
This is your case. So you can see your entry point for the nail, I guess you did the suprapatellar?
Suprapatellar, yeah.
Yeah. So your entry point for your nail is absolutely beautiful. It's exactly what you'd expect. But look at the corner of the nail. Actually, this screw would have allowed your nail to go down. So you could have put your plate on first very easily and then put your nail down. The only trouble with that is, you have to be a little bit careful, mindful of your screws distally to make sure the nail's able to go. Doing your nail first and your plate second is a little easier because you're less worried about your screws distally.
As you see, I've used a bit of the Herzog curve. I've played a little, cheated a little bit, and
Yeah,
put my entry a bit medially, so I'm in healthy bone, away from the condyle fracture.
Yeah, I think there'll be people watching this thinking, what if it had been bicondylar? What if there'd been a little condylar split going medially? Could you have put a medial plate on? Like that would have looked a bit like that previous X-ray, wouldn't it? Like
exactly.
plate here, and you nail down the middle.
It depends on the fracture and the bone quality. So you can clamp it and do your nailing with a clamp on.
Yep, that's right.
That's totally reasonable.
Right.
If you think it's stable enough, you can clamp and put your guide wires for your cannulated screws.
Yeah.
And do your nailing.
But actually, you could do something here that resembles that previous case.
Yeah, so it's not wrong to do a plate and nail.
Yeah.
It's not wrong.
Or indeed a double plate and nail.
But you have to do it to the right patient for the right injury, right?
Yeah.
Agreed. And one point to make. You asked me if I did this supracondylar. Suprapatellar, sorry. It's not the suprapatellar that matters. It's the position of the knee. It's the semi-extended position.
Got it.
It doesn't have to be. I prefer to fix the fractures with me and the X-rays moving around the bone, not the bone moving.
Yes, exactly.
You get what I mean,
I
right?
hear what you mean.
So if you get a nice reduction, why try and move the leg around?
The semi-extended is beautiful for that, and I agree. We shouldn't call it suprapatellar because
suprapatellar is a way to do a semi-extended nailing.
Got it.
Okay, and I prefer to do my nailing semi-extended.
Yeah.
Sometimes the kit is not available. I can do a medial or lateral parapatella, dealer's choice.
Yeah.
In a semi-extended position. That's more important, especially for the proximal tibia fractures.
Great.
Okay.
Lovely. So let's see what happened. Did it pass out? Did it get no, it didn't get a frame.
I think I let her walk a full weight bearing from the beginning.
Yeah.
I don't usually do that, but I did because it felt really solid when I fixed it.
Yeah.
And she wasn't a patient to partially weight bear. She would either be bed bound or fully weight bearing. So I trusted my fixation and let her fully weight bear.
Yep.
And it did well, I think.
Yep, that's great. So, thanks, Alex. That's great.
Yeah,
let's have some take-home messages here. So, I guess take-home messages. One is don't start by thinking about an implant. Don't look at the bone and think technical solution that needs a nail.
Because then, your thought process is around an implant. How am I going to fit a nail in there?
Yeah,
you forget about everything else.
Yeah, it all becomes nail-centric rather than patient-centric.
Exactly.
And the other thing is I think you'll bring out of this is characterize your soft tissue injury as well as your bony injury from the outset.
Exactly. You can go very cliche. The fracture is a soft tissue injury with a fracture.
Right. Yeah. Sure.
But also, beware. The closed complex fracture, right?
Beware the closed complex fracture.
Beware Dr. Jekyll. Mr. Hyde will show you who he is, right?
Mr. Hyde, he's running around the ED naked. Like, you know who Mr. Hyde is.
That was Mr. I thought he was one of our colleagues.
Mr. Jekyll is sitting over there in the waiting room, just like,
what a nice little old lady. And then,
imagine, oh man, the pus is flowing, and it's 1.5 years in a frame.
So that's it.
Cheers.
Cheers, OrthoHub. Thanks for having us. Thanks, Kash, for the valuable behind-the-scenes
And
input.
thank you, Kash, for your input.
Yes. We couldn't have done this without you.
That was great.